So imagine you push like 100 milligrams of succinylcholine.
Right, which is just your standard intubating dose.
Yeah, exactly. In a healthy, normal patient, you see that brief wave of fasciculations, the muscle twitches,
Uh-huh.
the vocal cords fall wide open, you intubate, and the surgery begins. I mean, it's completely routine.
Just another day in the OR.
Right. But today, you are absolutely not dealing with a normal patient. In the 14-year-old girl we were discussing today, the moment that succinylcholine hits her circulation,
The routine just totally shatters.
completely,
Mhm.
within like 90 seconds, her serum potassium skyrockets from a baseline of 4.0 straight to 8.5.
Oh, wow.
Yeah. The T waves on your monitor, they peak into these menacing spikes. The QRS complex widens all the way out, merging at the T wave into a sine wave.
Which is terrifying to see on the screen.
It really is. And before the surgeon has even picked up a scalpel, your patient is in hyperkalemic ventricular fibrillation.
You're running a code on a paralyzed, denervated patient.
Exactly. And the chances of resuscitation in that scenario are near zero.
It is the ultimate nightmare scenario for any anesthetist. And, the most terrifying part is that it is entirely iatrogenic.
Right. We caused it.
Exactly. The disease didn't kill the patient in that moment. The lack of physiological understanding did.
Well, welcome to the deep dive. We have a very specific, incredibly high-stakes mission today. You, the listener, you are a senior candidate walking into the grueling Gujarat University MD anesthesiology exam.
Yep. The hot seat.
And we are stepping into the roles of your senior MD anesthesia faculty. We're going to deconstruct this highly complex, multi-system case that is pretty much guaranteed to be an examiner favorite.
Oh, they love this one?
Yeah. We're drawing from advanced anesthesiology texts, critical care manuals, and high-yield MCQ banks to give you the ultimate mock Viva prep.
Because look, this specific scenario is an examiner's dream. It leaves you absolutely nowhere to hide.
You really can't bluff your way through this.
No, you cannot. You can't just rely on rote memorization of drug dosages here. This case, it aggressively tests your grasp of molecular neuromuscular biology, advanced pharmacology.
Like organ-independent clearance, right?
Exactly. Plus intricate fluid dynamics and the precise management of, complex surgical pathophysiology.
So let's just get straight to the facts of the clinical presentation. Imagine you are sitting right across from the examiner. They hand you a chart.
Okay.
You have a 14-year-old female patient. She is tiny, weighing only about 38 kilograms.
Very small for her age.
Yeah. She is a known case of spinal muscular atrophy, or SMA, which was diagnosed in early childhood.
Right.
And she has been entirely non-ambulatory since 2020. Her primary neurological presentation is quadriparesis with really profound proximal muscle weakness.
So that is her baseline physiology. She's already incredibly compromised. Now we add the acute surgical pathology that actually brought her to the operating theater today.
Right. The reason she's there, she has been diagnosed with a massive hydrometrocolpos.
Which is quite rare.
Yeah. And just for the surgical context here, this is a massive accumulation of fluid, often menstrual blood and secretions, that gets completely trapped in the uterus and vagina due to an anatomical outflow obstruction.
Right. And in this tiny 38-kilogram girl, this mass has grown so incredibly large, it is causing severe bilateral ureteric compression.
Just crushing everything.
Exactly. So the surgical plan is a major abdominal hysterectomy combined with double J or DJ stenting to, relieve the obstruction on her kidneys.
But wait, we also have to account for her congenital anomalies and the secondary damage from that mass, right?
Absolutely.
Because her ultrasound reveals a horseshoe kidney. And secondary to the mass effect of that giant hydrometrocolpos, she has mild bilateral hydronephrosis. There's also clinical suspicion of neurogenic bladder involvement linked back to her SMA.
Okay, so you are in the hot seat. The examiner taps the desk and says, "Doctor, give me a brief summary of this case."
Right. Now, my instinct here, especially given the acute pain and the obvious renal compromise, is to immediately frame this as an acute surgical emergency.
Like leading with the surgery.
Yeah. I'd want to say, I am presenting a 14-year-old female with obstructive hydrometrocolpos and acute renal compromise posted for hysterectomy. Because, the surgery is what we are actually doing today.
Right. But if you say that, the examiner will immediately tune you out.
Really?
Oh, absolutely. Leading with the surgical abdomen is a fatal flaw in an advanced viva.
Because the surgery isn't what's actually going to kill her on induction.
Exactly. The hydrometrocolpos is just the logistical reason she is in the hospital, but the spinal muscular atrophy, that is the physiological reason she might not leave it.
Wow, okay. That makes sense.
The systemic disease entirely dictates the anesthetic morbidity and mortality here. So your opening summary must be a masterclass in risk stratification.
You have to set the tone immediately.
Yes, you must prove to the examiner in the first 5 seconds that you respect that underlying pathophysiology.
So we need to draft a perfect, examiner-centric elevator pitch, something that hits all the high-risk points.
Exactly. What would that sound like?
Let me try. It should sound more like this. I am presenting a 14-year-old female weighing 38 kilograms with advanced non-ambulatory spinal muscular atrophy characterized by severe proximal quadriparesis.
Good start.
She is an exceptionally high-risk candidate posted for an abdominal hysterectomy and DJ stenting for an obstructive hydrometrocolpos.
Excellent. Now the anesthetic plan.
My anesthetic management will be entirely dictated by her profound neuromuscular denervation, her severely compromised respiratory reserve, the altered pharmacokinetics from her horseshoe kidney and obstructive hydronephrosis, and the anticipation of massive hemodynamic shifts upon decompression of her abdomen.
Flawless. Just flawless. You just told the examiner, hey, I see the traps.
Right, I haven't even mentioned a single drug dose yet.
You don't need to. You've already demonstrated consultant-level situational awareness.
Awesome. So since we've established that the systemic disease really drives the risk, we need to dive into the exact mechanisms at play here.
Let's look at the pathophysiology of spinal muscular atrophy.
Okay, so we're talking about a genetic neurodegenerative disorder. Specifically, the mutation affects the SMN1 gene, right?
Yes, the survival motor neuron 1 gene. And that mutation leads to the progressive degeneration of the anterior horn cells in the spinal cord.
And the anterior horn cells are essentially the lower motor neurons, correct?
Exactly. They're the final common pathway. So when they undergo apoptosis and degenerate, the electrical signal from the central nervous system simply cannot reach the peripheral muscle.
So the brain is firing, but the wire is cut.
That's a perfect way to put it. The muscle itself is structurally intact, but it is effectively orphaned.
It undergoes chronic denervation. And this is where the molecular biology gets incredibly relevant for us in the OR. Because an orphaned, denervated muscle doesn't just sit there quietly in atrophy, does it?
Not at all. It fundamentally changes its surface architecture. It panics. Well, in a healthy neuromuscular junction, you have these mature acetylcholine receptors, densely packed, but exclusively at the motor end plate.
Just in that one localized spot.
Right. When acetylcholine is released from the presynaptic nerve terminal, it crosses the synaptic cleft, binds to these highly localized receptors, and triggers a controlled influx of sodium and efflux of potassium.
And that depolarizes the muscle membrane and gives you a normal contraction.
Exactly. But the orphan muscle in SMA is starving for a signal. So it starts aggressively upregulating the synthesis of acetylcholine receptors and inserting them everywhere.
Everywhere, not just the end plate.
Not just at the end plate, but across the entire expansive surface of the sarcolemma. We call these extrajunctional receptors.
Extrajunctional.
Okay.
And crucially, these extrajunctional receptors are structurally distinct from mature adult receptors, right?
Very much so. A mature adult nicotinic acetylcholine receptor is a pentamer. It consists of 2 alpha subunits, 1 beta, 1 delta, and 1 epsilon subunit.
Okay, 2 alphas, beta, delta, epsilon.
Right, but the extrajunctional receptors that proliferate in these denervation syndromes are immature. They actually revert back to a fetal phenotype.
Wait, fetal? So what changes in the subunits?
The adult epsilon subunit is replaced by a fetal gamma subunit.
Epsilon becomes gamma.
Precisely. And that gamma subunit drastically alters the ion channel kinetics. Furthermore, the denervated muscle also begins expressing alpha-7 nicotinic receptors, which are homomeric, meaning they're made of 5 identical alpha-7 subunits.
I really want to focus on those kinetics because that is the physiological mechanism behind that massive hyperkalemic arrest I described at the very beginning of the deep dive.
It's the core of the danger.
These fetal gamma subunit receptors and the alpha-7 receptors, they have a vastly different relationship with depolarizing agents like succinylcholine compared to mature adult receptors, don't they?
They do. They are essentially faulty biological valves.
Faulty valves, I like that.
Think about it. When a mature receptor binds acetylcholine or even succinylcholine, the ion channel opens for roughly 1 millisecond. It's a fast, precise flutter. It's just a tiny blip.
Right. A tiny bit of potassium leaks out, raising serum potassium by a clinically insignificant amount, maybe 0.5 milliequivalents per liter.
Nobody even notices that on a blood gas.
Exactly.
Yeah.
But when succinylcholine binds to an extrajunctional receptor with a fetal gamma subunit, the channel stays open up to 10 times longer.
10 times longer.
Yep. Up to 10 milliseconds.
Wow. And because these receptors are plastered over the entire surface of the muscle, you suddenly have millions of ion channels flying open and getting stuck open.
Exactly. And the intracellular potassium, which is normally highly concentrated inside the muscle cell, just pours out down its concentration gradient directly into the systemic circulation.
It is a massive, uncontrollable efflux,
Completely uncontrolled. The serum potassium doesn't rise by 0.5. It rockets up by 3, 4, or even 5 milliequivalents per liter in a matter of seconds.
which instantly obliterates the resting membrane potential of the cardiac myocytes.
Hence the instant sine wave on the ECG and the intractable ventricular fibrillation. It's just fascinating to me how a genetic deletion in the spinal cord, years ago, dictates exactly which vial of muscle relaxant you are allowed to pull from your anesthesia cart today.
And being able to articulate that molecular understanding is exactly what separates the candidate from the consultant in an exam.
Absolutely.
Okay.
Let's expand this system-wise evaluation. We know her skeletal muscles are denervated and weak. How does this translate to her respiratory mechanics?
Well, we have a 38-kilogram patient who hasn't walked in 4 years. Her respiratory muscles, the diaphragm, and the intercostals are profoundly compromised.
And respiratory failure is actually the leading cause of morbidity and mortality in SMA, isn't it?
By far. When we look at her pulmonary physiology, we have to look way beyond just general weakness. Her vital capacity is drastically reduced, sure, but more importantly for the anesthetist, her functional residual capacity, her FRC, is decimated.
Right. FRC is our safety buffer. It's the oxygen reservoir that's left in the lungs at the end of a normal tidal breath. When we induce anesthesia and the patient stops breathing, the time it takes for them to desaturate is directly proportional to their FRC.
So in a healthy patient who is properly pre-oxygenated with 100% oxygen, you might have, say, 8 minutes of safe apnea time before the pulse oximeter drops.
That's a lot of time to intubate.
It is, but in this 14-year-old girl, because her FRC is practically non-existent, she will likely desaturate in less than 90 seconds.
90 seconds, that is terrifying.
It is, but it's not just the volume issue, it's the mechanics of the lung parenchyma itself.
Because her intercostals are too weak to generate strong negative intrathoracic pressure, right?
Right. She simply cannot take deep alveolar recruiting breaths. And this leads to chronic microatelectasis.
So thousands of tiny alveoli just collapse and stick together.
Yep. And this creates a massive intrapulmonary right-to-left shunt. Blood flows right past these collapsed alveoli without picking up any oxygen at all.
Furthermore, her weak bulbar and respiratory muscles mean she lacks an effective expiratory cough phase.
She can't clear her own secretions.
So any mucus plug becomes a potential airway obstruction and a prime nidus for postoperative pneumonia.
Exactly. Now, moving to the cardiovascular system, the case file notes her echocardiogram shows an ejection fraction of roughly 60% with mild mitral and tricuspid regurgitation.
Okay, an EF of 60% on paper looks like a green light. The left ventricle is pumping perfectly well.
It does look reassuring at first glance.
Well, wait, looking at the entire clinical picture, if she has severe respiratory compromise, that mild tricuspid regurgitation is actually a massive red flag, isn't it?
You are connecting the dots beautifully. You cannot look at the left heart in isolation when the lungs are failing.
Right. Because of her chronic microatelectasis and poor ventilation, she is likely suffering from chronic episodic hypoxia and hypercarbia,
which triggers hypoxic pulmonary vasoconstriction. The pulmonary arterioles clamp down to divert blood away from the collapsed lung zones.
But if most of her lung is poorly ventilated, the entire pulmonary vascular bed just clamps down.
Exactly. Her pulmonary vascular resistance is chronically elevated, so the right ventricle is forced to pump against that high pressure every single minute of her life.
So that mild TR on the echo, that might be the first sign of right ventricular dilation.
Spot on. She is operating on the very edge of right ventricular strain and potentially early cor pulmonale.
So if you do anything intraoperatively to further increase her pulmonary vascular resistance, like allowing hypercarbia or hypoxia or acidosis, her right heart could just fail entirely.
It absolutely could. It's a house of cards.
Let's pivot to the renal system. We have a horseshoe kidney complicated by hydronephrosis, secondary to the massive Hydrometrocolpos.
A horseshoe kidney presents really significant anatomical and physiological challenges.
How does it even form?
Embryologically, the metanephric blastemas fuse together, usually at their lower poles. This forms an isthmus that gets trapped under the inferior mesenteric artery as the kidneys try to ascend into the abdomen during fetal development.
So they get stuck lower in the pelvis.
Exactly. And their blood supply is highly aberrant, often drawing multiple accessory arteries directly from the lower aorta or the common iliacs.
Well, that makes the surgical field a massive bleeding hazard.
It does. But for our anesthetic plan, the immediate concern is the hydronephrosis.
Right, the massive Hydrometrocolpos is physically crushing the ureters.
Yes. This causes retrograde hydrostatic pressure straight up into the renal pelvis and into the major and minor calyces.
And this elevated pressure directly opposes the glomerular hydrostatic pressure, which drastically reduces her glomerular filtration rate, or GFR.
And as the GFR drops, her ability to excrete water-soluble drugs just plummets. Renal impairment drastically alters our pharmacokinetics.
Because if we use drugs that rely on renal clearance, their elimination half-life will be vastly, dangerously prolonged.
Exactly. Which brings us to our anesthetic risk stratification. How do we package all this complexity for the examiner?
Right. We have to categorize her as extreme, multifactorial, high risk. It's like a compounding triad.
Go ahead, lay it out.
First, profound neuromuscular denervation leading to altered receptor biology and lethal pharmacological traps.
Perfect.
Second, critical respiratory reserve with severely reduced FRC and secondary right heart strain.
Yes.
Third, altered pharmacokinetics due to obstructive nephropathy, all culminating in a major abdominal surgery that promises massive fluid and compliance shifts.
That synthesis right there proves to the examiner that you are anticipating the complications long before they happen.
Which naturally leads us right into Part C, preoperative optimization. I mean, we know we cannot fix these underlying derangements in the preoperative holding area, but we must optimize whatever marginal reserve she has.
Let's start with the airway assessment.
Okay, she's a Malampati II, and her mouth opening is adequate.
But given her SMA, we really need to look far beyond just the teeth and mouth. We must evaluate her cervical spine mobility.
Oh, because of scoliosis.
Exactly. Severe kyphoscoliosis is incredibly common in advanced SMA. That can make direct laryngoscopy incredibly difficult.
Good point. And what about her swallowing?
You must explicitly evaluate her bulbar function. You have to ask, how well does she swallow? Does she have a hypernasal voice? Does she frequently choke on liquids at home?
Because if her bulbar muscles are failing, she has essentially lost her native airway protection reflexes.
Exactly. She is at an astronomical risk of silent aspiration.
Got it. Now, for pulmonary function, typically we'd send a patient undergoing major abdominal surgery for formal spirometry, right? Like, we'd want to see her FEV1 or FVC, her flow volume loops.
Normally, yes. But in a 38-kilogram, 14-year-old girl with severe neuromuscular weakness, those formal tests are practically useless.
Why is that?
Because formal PFTs are highly effort-dependent. She likely lacks the muscular force to even form a tight seal around the mouthpiece, let alone generate a true forced expiration.
So the numbers you get back will just be artificially low and unreliable.
Exactly. You must rely on acute clinical bedside assessment.
What are we actually testing at the bedside then?
Ask her to count aloud as far as she can on a single maximal inhalation.
Oh, that's clever.
Yeah. A healthy person can easily reach 40 or 50. But if she gasps for air at 10 or 12, her vital capacity is critically low, likely well under 15 milliliters per kilogram.
Wow. And what about her cough?
You have to evaluate that, too. Is it a strong, explosive burst, or is it a weak, ineffective kind of bovine cough?
And a weak cough means she will require aggressive postoperative suctioning and pulmonary toilet because she simply cannot clear her own airway.
Exactly. Now, for the renal system, we need a strict baseline panel: urea, creatinine, and electrolytes.
Especially potassium, right? Given the massive tissue manipulation and fluid shifts expected.
Yes. We need to know exactly where her GFR stands before the surgeons place those double J stents.
Right, because we need to objectively measure if the stenting actually restores her renal function in the postoperative ICU phase.
Exactly. Okay, so we've assessed her deficits. How do we actually optimize her? We know we can't reverse the anterior horn cell death.
The primary goal of preoperative optimization here has to be aggressive pulmonary toilet. We want to maximize whatever functioning alveolar surface area she has left.
This means intensive chest physiotherapy. We employ postural drainage, percussion, and vibration to try and dislodge those thick, inspissated mucus plugs.
We'd use instead of spirometry too, right, if she can tolerate it.
Absolutely. To encourage sustained maximal inspiration, which really helps pop open that microatelectasis.
And we should consider prophylactic bronchodilators and perhaps mucolytics to thin the secretions.
The literature is unequivocal here. Preoperative respiratory optimization in neuromuscular patients significantly reduces the incidence of postoperative pulmonary complications, or POPCs.
Okay, let's talk about aspiration prophylaxis. We already established she has weak bulbar muscles, but she also has a massive pelvic mass.
Which is a huge factor.
Yeah, this Hydrometrocolpos is acting exactly like a full-term gravid uterus or massive ascites.
It is severely elevating her intra-abdominal pressure, and that pressure is transmitted directly up against the stomach, obliterating the normal pressure gradient across the lower esophageal sphincter.
So she is a massive risk for regurgitation the moment her consciousness is blunted.
Exactly. So we employ strict pharmacological prophylaxis based on Mendelson's criteria.
We need to alter the gastric fluid volume and its pH. If she does aspirate, we want the fluid to be minimal in volume and neutral in acidity to prevent severe chemical pneumonitis.
Right. We administer an H2 receptor antagonist like ranitidine or famotidine or a PPI the night before and the morning of surgery to halt gastric acid secretion.
And crucially, we administer a non-particulate antacid, like 0.3 molar sodium citrate, roughly 30 minutes before induction.
Sodium citrate works instantly to neutralize the acid that's already present in the stomach.
Exactly. You are buffering the gastric pH to greater than 2.5.
All right, her airway is assessed, her lungs are as recruited as they can be, her stomach acid is buffered. It is time to move her into the operating theater.
Which brings us to Part D, anesthetic considerations in SMA. This is the Pharmacological High-Wire Act.
The examiner will absolutely laser in on this section. Your entire plan must be built around 3 core tenets: managing her profound sensitivity to muscle relaxants, mitigating the extreme risk of prolonged apnea, and absolutely avoiding any drug that causes sustained respiratory depression.
We've already covered the succinylcholine trap in excruciating detail. We know the gamma subunit extrajunctional receptors will cause a massive potassium efflux and lethal cardiac arrest.
Succinylcholine is an absolute non-negotiable contraindication.
So how do we achieve surgical paralysis?
We must rely entirely on non-depolarizing muscle relaxants, NDMRs.
But wait, let's look at the pharmacology of NDMRs in denervation states. Generally, when you have an upregulation of extrajunctional receptors, you have a massive increase in the total number of acetylcholine receptors on the muscle membrane.
True.
So pharmacology texts usually tell us that in conditions like massive burns or upper motor neuron lesions, this massive increase in receptors means you need a higher dose of an NDMR to achieve a block, because there are simply more receptors to occupy.
That is true for those certain conditions. But SMA is a profound exception to that rule, and this is a very classic Viva trap.
Really? Why the exception?
Because in SMA, while there may be more receptors per square micrometer of muscle, the total functional muscle mass is absolutely decimated.
Oh, right.
The anterior horn cell death has led to such severe atrophy that her total neuromuscular reserve is nearly 0.
So even though the receptor density is high, the overall strength of the muscle is so fragile that even a minuscule dose of a blocking agent will completely obliterate what little tone she has left.
Exactly. SMA patients are exquisitely, profoundly sensitive to the clinical effects of NDMRs. If you give this 38-kilogram girl a standard intubating dose of rocuronium or vecuronium, she may remain completely paralyzed for hours.
And we compound that sensitivity with her renal status. Her hydronephrosis means her GFR is compromised. Rocuronium and vecuronium rely, at least in part, on renal and hepatic clearance.
So if her kidneys aren't filtering, those drugs will just recirculate, drastically prolonging her paralysis.
Which leads us to the gold standard choice for this specific patient, Cisatracurium, or preferably Cisatracurium.
Because they utilize Hoffman elimination?
Let's break down exactly what Hoffman elimination is, because examiners love to ask about the biochemistry. It is an organ-independent degradation pathway, right?
It is a non-enzymatic chemical breakdown. The Cisatracurium molecule spontaneously degrades in the blood plasma into inactive metabolites, primarily lodanosine and a monoquaternary acrylate.
So it doesn't need the liver's cytochrome P450 system, and it doesn't need the kidney's glomerular filtration.
Correct, but it isn't magic. It is strictly dependent on normal physiological conditions, specifically pH and temperature.
Right. Hoffman elimination requires a normal body temperature of around 37 degrees Celsius and a normal blood pH of 7.4.
So if her patient becomes severely hypothermic during this long abdominal hysterectomy, or if she becomes acidotic because our ventilation strategy is failing and her CO2 rises.
The Hoffman elimination will drastically slow down.
Exactly. If she becomes cold and acidotic, the Cisatracurium will stick around much longer, regardless of her kidney function. You must maintain perfect normothermia and strict normocarbia.
And even with Cisatracurium, we don't give a full dose. We titrate it meticulously, perhaps using 1/5 to 1/3 of the standard intubating dose, guided exclusively by continuous quantitative neuromuscular monitoring.
We'll discuss the exact mechanics of train-of-form monitoring during the extubation phase, but you must apply the peripheral nerve stimulator before you even push the induction drug.
Oh, to establish her baseline twitch strength.
Exactly, because her baseline will be inherently weak. You have to know what you're starting with.
Okay, we have our drug strategy. Part E, intraoperative management. Let's walk through the induction. We need to secure her airway, but she is a massive aspiration risk due to the Hydrometrocolpos,
Standard dogma for a full stomach patient is a rapid sequence induction and RSI.
where you pre-oxygenate, push a fast-acting hypnotic like propofol, immediately push succinylcholine, apply cricoid pressure, and intubate within 60 seconds without providing positive pressure mask ventilation.
But we cannot use succinylcholine. And Cisatracurium, even at a full dose, takes 2 to 3 minutes to provide ideal intubating conditions.
So this requires a highly modified RSI.
Yes. We must meticulously pre-oxygenate her for a full 3 to 5 minutes with 100% oxygen to maximize whatever tiny FRC she has.
We induce with an intravenous agent. Propofol is standard, but in a patient with a massive intra-abdominal mass, we have to consider her hemodynamics.
That mass is compressing her inferior vena cava, severely decreasing her venous return.
So if we push a standard dose of propofol, which is a potent venodilator, we might completely abolish her venous return and cause a catastrophic drop in cardiac output.
Excellent point. We must titrate the propofol very slowly, or consider a more hemodynamically stable agent like etomidate, though etomidate does carry the risk of adrenal suppression.
Alternatively, carefully titrated co-induction with fentanyl and a heavily reduced dose of propofol can maintain stability.
Once she is asleep, we push our fractional dose of Cisatracurium. Now we have a 2 to 3 minute window where she is apneic, but not yet paralyzed enough to intubate.
We apply gentle cricoid pressure to occlude the esophagus, but we have to be incredibly careful. In a tiny 38-kilogram patient with muscle atrophy, aggressive cricoid pressure can easily distort the airway anatomy and make laryngoscopy impossible.
And because her FRC is so low, she will desaturate rapidly. We cannot just let her sit there for 3 minutes.
We have to provide gentle, low-pressure mask ventilation to keep her oxygenated.
Yes, keeping the peak inspiratory pressure well below 15 centimeters of water to avoid opening the lower esophageal sphincter and insufflating the stomach.
Once the quantitative monitor confirms adequate blockade, we perform direct laryngoscopy and secure the airway definitively with a cuffed endotracheal tube.
The tube is in, bilateral air entry confirmed. We move to maintenance of anesthesia.
The primary goal here is to keep her hemodynamically stable, unaware, and pain-free, while fiercely protecting her respiratory drive for the postoperative period.
This means we must implement an opioid-sparing multimodal analgesic strategy.
Opioids like fentanyl or morphine are fantastic analgesics, but they're potent respiratory depressants. They act directly on the mu receptors in the medullary respiratory center, shifting the CO2 response curve to the right.
Meaning her brain will tolerate much higher levels of carbon dioxide before triggering a breath.
In a healthy patient, this is manageable. But in an SMA patient with failing intercostals, this rightward shift means she simply will not breathe postoperatively.
So we attack the pain pathways from every other angle. We use intravenous paracetamol, which works centrally on the COX pathway.
We can use low-dose ketamine, which is an NMDA receptor antagonist, providing profound analgesia without depressing the respiratory drive.
We can use dexmedetomidine, an alpha-2 agonist, which provides analgesia and anxiolysis while leaving the respiratory center completely intact.
And we heavily utilize regional anesthesia. The surgical incision for an abdominal hysterectomy is extensive.
A thoracic epidural would be incredible here. It provides dense somatic and visceral analgesia.
It would be, but wait, we have to look closely at her spine. Severe scoliosis is incredibly common in advanced SMA, like you mentioned earlier.
Yes. The vertebral rotation and ossification might make epidural placement anatomically impossible or drastically increase the risk of dural puncture or neurological injury.
If the neuraxial route is blocked, we rely on fascial plane blocks. Bilateral transversus abdominis plane, or TAP blocks, or quadratus lumborum, QL blocks, performed under ultrasound guidance, will significantly reduce the somatic pain of the abdominal incision.
Which drastically reduces her need for systemic opioids.
Let's discuss our ventilation strategy while the surgeons are working. We are controlling her breaths.
We must employ strict lung protective ventilation. Her lung tissue itself might be relatively normal, but her chest wall mechanics are destroyed.
So we use lower tidal volumes, roughly 6 to 8 milliliters per kilogram of her ideal body weight, which is quite small.
And we must titrate our positive and expiratory pressure, our PEEP. We need enough PEEP to overcome the compressive weight of the Hydrometrocolpos and stent open those microatelectatic alveoli.
But not so much PEEP that we impede venous return to her already stressed right heart.
Exactly, and we have to be hyper-vigilant of the surgical progress. Right now, her respiratory compliance is terrible because the massive mass is pushing up against her diaphragm.
We might require relatively high airway pressures just to deliver those small tidal volumes.
But the moment the surgeon successfully drains or removes that giant Hydrometrocolpos, the physiological landscape of her abdomen and thorax changes instantly.
The diaphragm suddenly drops. The physical restriction is just gone. Her lung compliance will skyrocket.
If we leave the ventilator on the exact same pressure settings, the next breath will deliver a massive, potentially damaging volume of air, causing severe barotrauma or volley trauma.
You must communicate constantly with the surgical team. When the mass comes out, you immediately dial down your inspiratory pressures.
You will also see a sudden shift in your end-tidal CO2 as the dead space and functional lung volumes dynamically alter.
This surgical milestone, the removal of the mass, triggers an even more dangerous crisis in our fluid management. This brings us to the concept of PICD, paracentesis-induced circulatory dysfunction.
This is a high-level physiological concept. While the mass is in place, it is massively increasing intra-abdominal pressure.
This pressure acts like a mechanical tourniquet on the splanchnic venous bed, the massive network of veins in the mesenterian gut.
The blood is physically squeezed out of the abdomen and into the central circulation.
But when the surgeon removes the mass, that external tourniquet is suddenly released. The intra-abdominal pressure plummets.
And the entire splanchnic vascular bed undergoes massive instant vasodilation. It's like opening a floodgate.
A huge percentage of her circulating blood volume suddenly pools in her gut.
Venous return to the right atrium drops to near zero. Cardiac output crashes, and her mean arterial pressure plummets.
This is where the trap snaps shut. You see her blood pressure crash into the 50s. The reflexive, panicked response is to open the IV fluids wide open and rapidly infuse liters of crystalloid to fill the tank.
And if you do that, you will kill her.
Why? I mean, she's hypotensive.
Because the tank isn't empty, it just got temporarily wider. If you flood her with 2 liters of normal saline, you will acutely raise her hydrostatic pressure.
And because of her SMA, her lungs are already on the brink.
Exactly. That fluid will extravasate out of the pulmonary capillaries directly into the alveoli.
You will cause acute fulminant pulmonary edema, and a patient with SMA cannot cough up that fluid, nor can they breathe through it. You will drown her. So what is the physiological solution to PICD?
You manage the vascular tone, not the volume. You anticipate the drop.
The moment the mass is removed, you administer a highly titrated dose of a direct alpha-1 agonist like phenylephrine or norepinephrine.
You pharmacologically squeeze the splanchnic veins. You constrict the dilated vessels, forcing the pooled blood back into the central venous circulation.
Restoring preload and cardiac output without adding a single drop of excess fluid that could threaten her lungs.
That is exactly how you manage it. And you balance this tightrope while carefully ensuring her horseshoe kidney receives just enough mean arterial pressure to maintain glomerular filtration.
Specifically monitoring the urine output as the surgeons place the double J stents.
The surgery concludes. The Hydrometrocolpos is out, the ureters are stented, the abdomen is closed. We transition to Part F postoperative management.
For a healthy patient, this is where you relax. For an SMA patient, this is where the true peril begins.
The extubation strategy, taking the breathing tube out.
There's an ironclad rule here. We cannot extubate this patient deep. She must be fully, absolutely awake.
Deep extubation is sometimes utilized to avoid coughing and hemodynamic spikes on emergence, but it relies on the patient's intrinsic pharyngeal tone to keep the airway patent while they sleep off the anesthetic.
And an SMA patient has virtually no intrinsic pharyngeal tone.
None. If you pull the tube while she is even slightly sedated, her tongue and soft tissues will immediately collapse against the posterior pharynx. She will completely obstruct.
And because of her profound diaphragmatic weakness, she will not be able to generate the negative pressure required to overcome the obstruction.
She must be fully conscious, following commands, and purposefully maintaining her own airway. And we must objectively prove that every single molecule of our muscle relaxant is gone.
We return to our quantitative train of 4 monitor. We stimulate the ulnar nerve and measure the adductor pollicis twitch. We are looking for a T-off ratio of greater than 0.9.
Meaning the fourth twitch is at least 90% as strong as the first.
Why is that fade important?
Because Cisatracurium is a competitive antagonist, it exhibits fade on the monitor. As the nerve is repeatedly stimulated, less acetylcholine is released, and because the receptors are partially blocked, the subsequent twitches get progressively weaker.
So a ratio of 0.9 ensures minimal residual receptor occupancy.
Right, but let's be clinically realistic here. Even if the monitor says 1.0, she's still going to be incredibly weak.
Right, the monitor only tells us the drug is gone. It doesn't cure her SMA.
Exactly. The monitor simply confirms we haven't added iatrogenic weakness to her baseline pathological weakness.
And since we use Cisatracurium, which undergoes Hoffman elimination, do we still administer pharmacological reversal agents?
We do, to guarantee absolute clearance of any lingering blockade. But we must be very careful with the pharmacology of neostigmine.
Neostigmine is an acetylcholinesterase inhibitor. It works by blocking the enzyme that normally breaks down acetylcholine in the synaptic cleft.
This causes a massive buildup of acetylcholine, which competitively physically outcompetes the remaining cisatracurium molecules for the receptor sites.
But neostigmine has a ceiling effect, doesn't it?
It does. Once you inhibit 100% of the acetylcholinesterase enzyme, giving more neostigmine does absolutely nothing to help reversal.
In fact, an overdose of neostigmine can paradoxically cause weakness, a depolarizing neuromuscular block, because the massive flood of acetylcholine keeps the receptors constantly open and unable to reset.
A cholinergic crisis, and we administer it alongside an anticholinergic, like glycopyrrolate, to block the unwanted muscarinic side effects, like extreme bradycardia and massive salivary secretions.
Which would be disastrous in a patient who cannot swallow effectively.
The tube comes out, she is awake, she goes immediately, without delay, to the intensive care unit, not the PACU, not the surgical ward.
The primary postoperative risk is acute hypoventilatory respiratory failure. The surgery took a massive toll on her marginal reserve.
The most critical intervention in the ICU is the immediate prophylactic application of non-invasive ventilation, NIV. We are talking about CPAP or BiPAP.
We don't wait for her to desaturate. We apply it prophylactically. Let's explain the mechanics of why CPAP is life-saving here. It provides continuous positive airway pressure. It acts as a pneumatic splint.
It blows a constant column of pressurized air into her airways. This physical pressure holds the upper airway open, preventing pharyngeal collapse.
But more importantly, it transmits down into the lungs and physically pops open the microatelectasis.
It recruits collapsed alveoli, drastically increasing her functional surface area for gas exchange.
And it significantly decreases her work of breathing. The positive pressure assists her failing inspiratory muscles, allowing them to rest and recover from the trauma of the surgery.
And we manage her pain strictly with our multimodal regimen. A morphine PCA in the ICU for an SMA patient is a death sentence.
Because the opioids will silently blunt her hypercarbic drive, her CO2 will slowly climb, she will slip into CO2 narcosis, and she will arrest.
We must rely on our tap blocks, scheduled paracetamol, and ketamine infusions. We must protect her respiratory drive at all costs.
Let's transition to Part H exam integration. How does the candidate take all of this physiological depth and structure it perfectly for the examiner?
The examiners love to test your depth of understanding by asking you to differentiate similar-sounding diseases.
Oh, like a compare and contrast.
Exactly. The classic Viva trap is asking you to contrast the anesthetic management of spinal muscular atrophy with Duchenne muscular dystrophy, DMD.
Both are devastating neuromuscular diseases affecting young patients, both present with profound weakness.
But their underlying pathophysiology and therefore their anesthetic risk profile is diametrically opposed.
Let's break it down for the listener. Duchenne muscular dystrophy is a primary muscle disorder. It is a myopathy.
Yes. In DMD, there is an X-linked genetic defect resulting in the absence of a protein called dystrophin.
What does dystrophin actually do?
Dystrophin acts as a structural anchor. It links the internal actin cytoskeleton of the muscle fiber directly to the extracellular matrix.
So without dystrophin, the muscle cell membrane, the sarcolemma, is structurally incredibly fragile.
Exactly. Every time the muscle contracts, the membrane physically tears.
And this constant tearing leads to chronic rhabdomyolysis, muscle necrosis, and eventually the muscle is replaced by fat and fibrotic tissue.
SMA, on the other hand, is a neuropathy. The muscle membrane is perfectly structurally intact.
The disease is in the spinal cord. The anterior horn cells die, and the muscle simply loses its nerve supply.
So why does the examiner care if you know the difference between a myopathy and a neuropathy?
Because it completely changes the mechanism of the succinylcholine trap. In both diseases, succinylcholine is absolutely contraindicated. It will cause hyperkalemic cardiac arrest in both. But the why is completely different.
Let's hear it.
In SMA, as we've discussed endlessly, succinylcholine triggers massive potassium efflux through the upregulated immature extrajunctional acetylcholine receptors on the denervated muscle.
Right. But in Duchenne muscular dystrophy, the extrajunctional receptors aren't the primary issue.
When you give succinylcholine to a DMD patient, the fasciculations, the vigorous, uncoordinated muscle contractions it causes, physically rip those fragile dystrophin-deficient muscle membranes apart.
It induces massive acute rhabdomyolysis. The muscle cells literally burst open, dumping all of their intracellular potassium and massive amounts of myoglobin directly into the bloodstream.
The hyperkalemia stops the heart, and the myoglobin rapidly clogs the renal tubules, causing acute kidney injury. It is a mechanical destruction of the muscle, not a receptor-mediated ion channel leak.
Furthermore, the systemic focus is different. In SMA, the primary threat is respiratory failure due to motor weakness. The heart is largely structurally spared, at least until secondary core pulmonale develops.
But in DMD, the absence of dystrophin also heavily affects the cardiac myocytes. DMD patients develop severe, progressive, dilated cardiomyopathy. Their cardiac reserve is often fundamentally destroyed.
If you can clearly articulate the difference between the receptor-driven hyperkalemia of SMA and the rhabdomyolysis-driven hyperkalemia and cardiomyopathy of DMD, you prove to the examiner that you understand the cellular biology, not just the textbook warning boxes.
Let's run through a rapid-fire mock viva. I will play the gruff, impatient examiner. I'm going to interrupt you and push you on the key concepts. Ready?
I'm ready. Bring it on.
Doctor, you're inducing this 14-year-old girl. You need her paralyzed quickly. Why not just use succinylcholine?
Sir, succinylcholine is absolutely contraindicated due to the risk of lethal hyperkalemia. SMA causes profound lower motor neuron denervation. This denervation triggers the massive upregulation of immature, fetal variant extrajunctional acetylcholine receptors, specifically those containing a gamma subunit across the entire sarcolemma. Succinylcholine will cause prolonged opening of these channels, leading to an uncontrolled, massive efflux of intracellular potassium, resulting in immediate hyperkalemic ventricular fibrillation.
Fine, you use a non-depolarizing agent. But she has extrajunctional receptors. Doesn't that mean she needs a huge dose of rocuronium to block them all?
No, sir. While receptor density is increased, her total functional muscle mass is critically reduced due to profound atrophy. She is exquisitely sensitive to non-depolarizing muscle relaxants. A standard dose would result in drastically prolonged paralysis. Furthermore, given her hydronephrosis and potential acute renal impairment, I would avoid rocuronium entirely and utilize a reduced, carefully titrated dose of Cisatracurium, as its Hoffman elimination ensures predictable clearance independent of her compromised glomerular filtration rate.
The surgery's done. She's moving a little. Her tidal volumes look okay. I want to turn over the room. Can you extubate her now?
I will absolutely not extubate her until she is fully conscious and purposefully responsive. Clinical signs like tidal volume or spontaneous movement are dangerously deceptive in a patient with baseline neuromuscular disease. I must rely on objective quantitative trainiform monitoring to confirm a ratio of greater than 0.9, ensuring complete reversal of the neuromuscular blockade. Even then, due to her inherent diaphragmatic weakness and decimated functional residual capacity, she remains at extreme risk for airway collapse and hypoventilation. She requires fully awake extubation and immediate transfer to the ICU for prophylactic non-invasive ventilation.
Excellent. Pass. That is exactly how you handle the pressure. You don't just state the action. You relentlessly tie it back to the cellular mechanism.
And for the written exams, you must translate this clarity into visual structure. The examiner is grading hundreds of papers. A massive block of text will bury your brilliance.
You need flowcharts. Draw an SMA pathophysiology flowchart. Start with a box labeled SMN1 gene mutation. Draw an arrow to anterior horn cell degeneration. Arrow to chronic muscular degeneration.
Branch that out. One arrow goes to extrajunctional receptor proliferation, leading to a bold red box. Succinylcholine contraindicated lethal hyperkalemia.
The other arrow goes to diaphragmatic atrophy, leading to decreased FRC and microatelectasis.
Draw a second flowchart for your anesthesia plan. Pre-op. Aggressive pulmonary toilet and Mendelson's prophylaxis.
Intra-op. Modified RSI, Cisatracurium titration, multimodal opioid-sparing analgesia, lung protective ventilation.
Post-op. Awake extubation, strict ICU monitoring, prophylactic CPAP. Visually structuring your answer guarantees the examiner sees that you grasped the entire perioperative continuum.
Let's quickly recap the absolute highest yield concepts we've covered today.
1. Spinal muscular atrophy is a lower motor neuron disease, meaning it is a neuropathy characterized by chronic denervation, differentiating it entirely from myopathies like Duchenne muscular dystrophy.
2. Chronic denervation causes the proliferation of fetal variant extrajunctional acetylcholine receptors, making succinylcholine an absolute lethal contraindication due to massive potassium efflux.
3. Despite the receptor upregulation, the profound muscle atrophy makes these patients exquisitely sensitive to non-depolarizing muscle relaxants. You must use minimal titrated doses.
4. Because this specific patient has an obstructive hydrometrocolpos causing hydronephrosis, her GFR is compromised. You must utilize Cisatracurium or Atracurium to take advantage of organ-independent Hoffman elimination.
5. The respiratory pathophysiology is defined by profound weakness, drastically reduced functional residual capacity, microatelectasis, and an inability to clear secretions. Preoperative pulmonary optimization is mandatory.
6. The massive pelvic mass acts as a full stomach, requiring strict pharmacological aspiration prophylaxis and a carefully modified rapid sequence induction.
7. The surgical release of the hydrometrocolpos will cause paracentesis-induced circulatory dysfunction, PICD. The sudden drop in intra-abdominal pressure will cause massive splanchnic vasodilation and a precipitous drop in preload.
8. You must treat this hemodynamic crash with alpha-1 agonists like phenylephrine to restore vascular tone, rather than flooding her delicate lungs with crystalloid fluids.
9. Maintain a strict opioid-sparing multimodal analgesic regimen utilizing paracetamol, NMDA antagonists, alpha-2 agonists, and regional fascial plane blocks to fiercely protect her fragile postoperative respiratory drive.
And 10. Extubation must occur only when she is fully awake, objectively fully reversed via quantitative monitoring, and she must be immediately transitioned to prophylactic CPAP in the ICU to splint her failing airways open.
If you understand the deep physiological why behind those 10 pillars, there is not a single question an examiner can ask that you cannot logic your way through.
We've spent this entire deep dive building our anesthetic plan around a fundamental, unshakable dogma. Spinal muscular atrophy causes chronic denervation, denervation causes extrajunctional receptors, and extrajunctional receptors make succinylcholine a lethal weapon. It is the absolute bedrock of our current understanding.
It is the physiological truth we have operated under for decades.
But I want to leave you with a final provocative thought. Medicine is never static. We are currently witnessing a revolution in the treatment of SMA. We have entered the era of advanced genetic therapies.
Drugs like nusinersen, an antisense oligonucleotide that modifies RNA splicing to increase functional SMN protein.
Or Zolgensma, which is literally a viral vector delivering a fully functional copy of the human SMN1 gene directly into the patient's motor neurons.
The clinical results are staggering. Children diagnosed with SMA who receive these therapies early enough are achieving motor milestones that were historically impossible. They are sitting up, they are walking.
The anterior horn cells are surviving.
Which fundamentally alters the natural history of the disease.
Exactly. And it raises a profound physiological question for the anesthetist of the future. If a viral vector successfully delivers a functional gene and the anterior horn cells recover, and they successfully reinnervate the peripheral muscle, what happens to the sarcolemma?
Right. Does the denervation hypersensitivity recede? Do those immature fetal variant gamma subunit extrajunctional receptors disappear once the muscle is no longer starving for a signal?
If the muscle membrane architecture normalizes, does the succinylcholine trap vanish? 10 years from now, will a candidate sit in that exam chair, be presented with an SMA patient who received Zolgensma as an infant and correctly state that succinylcholine is safe to use?
It is a brilliant question. It forces us to realize that as genetic therapies fundamentally change the underlying phenotype of the disease, our strict pharmacological rules must adapt. The textbook contraindications of today might be entirely obsolete tomorrow.
You cannot just memorize the rules. You have to relentlessly question the mechanisms. Because when the genetic mechanism changes, the rule changes. Keep studying the physiology, stay intensely curious about the emerging science, trust your preparation, and go confidently dominate your exams. You are ready.
Best of luck to you all.